Hi, my name is Jessica Anker. I'm the co-director of the Health Informatics Training Committee, and I'm here to tell you a little bit about the larger context of our training program and what we're hoping to prepare you to do while you're here with us. The larger context of our training program is really the problems facing the American healthcare system. It will not be a surprise to anyone listening to this that the United States spends far more on healthcare than any other developed nation. And at least as a part of those high costs, we have a lot of patients without good access to the medical system. A lot of patients are uninsured and do not have a primary care provider. Outcomes are not great either. Here's our infant mortality rates. You can see that we're way down at the bottom of this list of developed countries. And when we admit patients to hospitals, we frequently make mistakes. This study came out earlier this year showing that adverse events occurred in 1/3 of all hospital admissions. These sorts of facts have led to a nationwide attention to the problem of medical errors in these Institute of Medicine reports. We have tremendous problems coordinating and communicating across physicians in the care of a single patient. Care coordination is this collaboration, and again, you can see that we rank pretty far down the list of developed countries in this indicator as well. Within our country, we have this sort of troubling and unexplained discrepancies in both the cost of care and the types of care, the quality of care that we are offering to our patients. Another problem is a lag between research evidence and routine practice. It takes an estimated 17 years for research findings to actually make it out into the field where they are benefiting the patients that they're intended to benefit. And then we have another enormous problem in this disconnect between the medical system and the patients it's meant to serve. We have literacy and numeracy problems that mean that a very small number of our patients really have very good skills to be able to manage their own health care. Another half have what are called intermediate level skills in that they can really read and interpret prescription labels, but 22% have basic skills and 14% have below basic skills, either difficulties reading and communicating in English or severe difficulties with literacy. All of that adds up to an incredibly complex set of problems facing the American healthcare system today. So to talk about how informatics might start to help, I'm going to show you a model of how we currently turn data into knowledge. The healthcare system rests on a basis of research data. We do a series of studies in which we collect information from patients. And then we turn that data into medical knowledge. So for example, we might do research on patients with diabetes, and we learn that a certain percentage of them benefit from insulin, and we might learn the correct doses to give to them under different circumstances. This medical knowledge slowly filters its way out into the way different doctors treat patients, and then at each clinical encounter, that doctor makes some notations about what was done with that patient in paper-based medical records. There are a lot of problems with this system. I mean, the good part is that it's based on evidence. The bad part is it takes a lot of money and a lot of time to do really good research. It's hard to recruit patients. You need a huge amount of infrastructure to really do good research studies in medicine. A second barrier is that once we've turned that into medical knowledge, how do we get it out into the field? Well, we might publish it in journals, we might publish textbooks, we put it into medical school curricula, but you can still see that even if we train today's generation of doctors, it's increasingly difficult to get it out into the minds of all of the different providers who are out there in the field today. Another issue is that when we have these paper-based medical records scattered among all of the different doctors' offices and hospitals in the country, it's very hard to get any information back out of those and turn that into research. You need armies of research assistants to go and collect medical records and abstract information out of them, reading poor handwriting and misfiled files and all sorts of things to get any research data back out of that. Finally, there's a fair amount of disconnect between that medical research infrastructure and the patients. Patients are not typically engaged in the way research is conducted, and they are not necessarily extremely well informed about their own medical care, let alone the way medical knowledge is created. What we're striving for as a society is something that we call a learning healthcare system. We still want research data to be collected. We still want to distill that data into medical knowledge. And we certainly still want doctors to use that to treat patients. One thing that we want to change, however, is instead of these paper records, we would like to build a really good health information technology infrastructure, including electronic health records that would capture and store patient data. One advantage of that is that we could then really do a much better job of creating teams of providers who all have access to that same shared medical record, who can communicate with each other electronically while looking at the same set of patient data. So for example, patient primary care provider goes to the cardiologist, both the primary care and the cardiologist document their care in the same record, and then they can see what each other are doing. Another huge advantage of these electronic systems is this very exciting possibility that they can actually be shared with patients and create a much more tightly bound team of patients and providers on the same side, where they're really looking at that same information and communicating about it. One of the tremendously exciting potentials of health information technology, such as electronic health records, is the possibility that medical knowledge can be programmed directly into it in the form of things like alerts and reminders and knowledge bases, so that a really good electronic health record with all of these technologies becomes a piece of smart technology that can help providers select the correct dose for their patient without having to memorize or perform calculations, that can alert the doctor that this particular patient is allergic to penicillin and shouldn't be given it. A really good set of health information technology is far more than just a paper-based record of the patient. It is actually has the potential to be an active participant in the care of the patient. Another great potential for a really good health information technology infrastructure is that we could really do a much better job of communicating with public health, helping do things like statewide and nationwide disease surveillance, helping create shared immunization records for children and adults across the country. That's another form of communication that typically today takes place with paper, and tomorrow really could take place in electronic systems instead. And finally, once we have these systems and they're populated with really rich data about patients, we could then abstract that data back out for research purposes. We could do it in the short term to create what are frequently called business analytics or quality improvement initiatives, where we can look at right now how many patients have had an adverse event, right now how much are we spending on patients, in order to make informed and high-quality decisions about what we're supposed to do within our healthcare organizations. And then stepping back, we have the potential to do very exciting epidemiological research, large-scale trials with access to far larger pools of data at potentially lower cost than has previously been possible. So this learning healthcare system in theory, facilitates communication among all of the different parties involved, patients and providers, public health, also insurers, also the healthcare organizations themselves, and speeds up the transactions so that data turns into knowledge, turns into practice, and then that practice in turn informs research and our broader knowledge of really what's going on in the healthcare system. So the problem with this dream is that it's really hard to do. We're not there yet, and it's going to take us a while. There's a wide variety of reasons of why it's hard. you may recognize that we do have a lot of electronic health records out in the field right now, and a lot of different doctors are using them. Well, here's one problem, is that it's well recognized that the user interfaces of the technologies that are out there are far less sophisticated than the sorts of user interfaces you are accustomed to on your iPhone or your Android. Consumer technologies typically are extremely user-friendly. They're in fact fun to use. Electronic health records are not. Doctors frequently complain that they require a lot of clicks, a lot of form filling, and that they're somewhat clunky and slow to use, that the systems are not actually helping them think about patients, but rather requiring them to spend a lot of extraneous time documenting. So there's one barrier right there that we can start to look at, is how can we create a user interface that helps doctors think about their patients rather than gets in the way of thinking. There's another problem, which is that healthcare is, as we mentioned before, delivered in teams. So even if we optimize a particular product to a particular doctor, how do we know that it's really going to facilitate communication across doctors and across organizations? Right now, it's still pretty difficult to get data out of one electronic system and pass it to another system in another organization. We will spend a lot of time in our coursework talking about why that is, what the solutions are, and how we can actually promote those solutions. Another problem, of course, is that different patients have different needs. We have incredibly heterogeneous groups of patients, and not only that, but medical data about those patients is very complex. It's much more complex than, say, banking data. So, again, solutions that are customized to one patient or one particular type of patient might not really work for all of the different types of patients that we need to take care of. Another huge problem that I alluded to earlier is the distinction between the types of vocabulary used by doctors and the types of vocabulary used by patients. When we make these records, these electronic health records, available for patients to view, we typically find confusion, alienation. Patients have no idea what they're looking at or how they're supposed to respond to it. So there's a tremendous need to translate this information into a user-friendly format. Healthcare takes place in organizational settings, and it's a complex teamwork approach to almost everything that happens. And what we find is that systems, say a technology system implemented in one setting, may or may not be successful in other settings due to huge variation in the way people work in those settings, what their organizational policies are, how interactions take place. And then another level of challenge is that the way we practice healthcare in America is strongly affected by national policy. Things like privacy laws, things like physician reimbursement laws, and changes in those can create sea changes, earthquakes in the way medicine is practiced, and can certainly affect the health information technology as well. All of these factors are moving rapidly, adding complexity to anything that we do in the technology world. Okay, so what are we trying to do here to help you get involved in these very exciting discussions and technology innovation that's happening today? One set of skills and knowledge that we're going to be having you learn more about is obviously medicine and healthcare. In our classroom, we frequently have students who are healthcare providers, as well as students who are technology specialists, computer scientists, engineers, or scientists. So we will be formally introducing you to a wide variety of issues in the American healthcare system and bringing you to observe medical care sites. Those of you doing research projects will these will take place in medical settings so that you can learn more about the way the healthcare system works. There's definitely a grounding of computer science and information technology. We will be talking a lot about the different technologies that are available, as well as some of the component disciplines, such as database creation, things like that, that are underlying a lot of these. We will require coursework in statistics and epidemiology. That's really for two purposes. One is we need students to start to understand how to analyze the data that's coming out of electronic health records. And the second reason is that we need students to understand rigorous research methods so that they can be more savvy consumers of the information that's being generated about our healthcare system. There's a strong component of engineering, software engineering in terms of developing new technologies, but also other engineering techniques that are not software engineering. So we'll be introducing you to various human factors engineering approaches, as well as business model approaches that are based upon engineering as well, such as processes, workflow diagramming. I'm sorry about that. I went the wrong way. Another component is that these technologies are used by human beings, and not human beings only in isolation, but also groups of human beings. So we are going to give you introduction to the social and the behavioral sciences, things like psychology, cognitive psychology, also things like questionnaire design, so that you can understand how these can support the technology that needs to happen. We will be talking a fair amount about cognitive science, how people think, how people make decisions, because those things can be strongly influenced by technology, by the technology that they're using. Cognitive science is also underlying a lot of the usability research that's ongoing today. And all of this is, we're going to wrap this all in a wrapper of public policy. We really need all of our students to understand the larger societal and governmental context of healthcare and health information technology in America today. To give you a flavor of this last one, this combination of skills and knowledge is what the field of health informatics really is all about. So to give you a flavor of the most important public policy issue that we're facing today in the realm of health information technology, I want to introduce you to the Meaningful Use Program. The Meaningful Use Program originated in a law passed in 2009 called the HITECH Act. And this created a federal incentive program to get doctors to computerize their medical records. This was called the Meaningful Use Program because the goal was not just to get doctors to buy the technology and use it as a doorstop, but in fact to put it into their practice of medicine and use it in a quote-unquote meaningful way. So the program set aside about $45 billion, most of this for actual financial incentives for doctors and hospitals to computerize their medical records and demonstrate that they are actually using them in patient care. As a result of this, you can see there's been a rapid increase in the number of U.S. physicians who are using electronic health records. Today, it's better than 3/4. I certainly anticipate that this proportion will be higher than 90% in the next few years. Meaningful use takes place in what's known as a staged approach, meaning that doctors and hospitals can get on the bandwagon with a relatively basic level of use of the technology, but then they are expected to progress. So in stage 1, they had to install these things and start using them. In stage 2, they actually had to do things like giving patients access to the records and creating electronic summary records. In stage 3, the details are still being worked out, but the goals will become even more stringent. So what we're seeing today is that it's no longer a question of getting doctors really to adopt this technology. It is now much more a question of making the technologies better and making sure that they actually serve the needs of both doctors and patients. As a result, we want to put a bunch of people out there in the field who have a really strong understanding of the healthcare system, who have a strong understanding of the technologies that are available and the ones that are not yet available and that could be available. We want our students to understand research methods, statistics, as well as social and behavioral sciences so that they can be savvy consumers and savvy creators of the next generations of technologies. And we want people to understand this all from a public policy perspective so that we don't have pie-in-the-sky technologies being developed that are not going to be able to be worked with the current healthcare system. We need people to know how to get from here to the pie in the sky. So I'd like to leave you just with a couple of final points. We really think that good health information technology is critical to fixing the many problems in the current healthcare system. But creating good health information technology is not easy. There are a lot of complaints about the technology that's out there today, and we really need a multidisciplinary perspective to get it to the next level. Our health informatics graduate programs are meant to introduce you to the policies, the methods, and the technologies so that you have the tools and the knowledge at your disposal to jump into this mess that is the American healthcare system and start doing your part to create creative solutions that are going to try to get us to the next level. I'd like students to do a couple of things at the end of this lecture. Please take a look at our website to look at some of the faculty profiles and see what sorts of research and innovation are going on. I'd like you to visit healthit.gov. That's the website of the Office of the National Coordinator for Health Information Technology, and just start poking around on that website so you can see a little bit about the federal policy initiatives that are going on in this area. It's mandatory that all of our students subscribe to at least one informatics newsletter or blog. I've given you 3 suggestions there, but I'm also certainly open to other suggestions from other people. This is because this is a rapidly changing policy environment, and the only way that you can keep your finger on the pulse is to listen to what's being said about this every day. And for all of our students, I also want you to start becoming familiar with the wide range of different types of research that are going on in this field. So I'd like everybody to subscribe to at least one table of contents alerts. These, I've given you 3 journals to as a place to start looking. You can subscribe to the alerts, in which you'll get an email once a month or however often the journal is published with a list of the articles that are published that month. And then you can start skimming the headlines and selecting articles that you think that might be interesting to read or relevant to your own work. With that, I will say goodbye. I'm looking forward to seeing all of you in the various different classes. And I also look forward to hearing from people who might have any sorts of questions. Thank you very much, and good luck.